Forward to the cloud. I just did that.
Great. Congratulations. I'm going to stay as long as I can, but I may not be able to stay because I have to be up again for Taiwan.
Okay.
Thanks, Jen.
Can everyone see my screen? Okay. Happy International Nurses Week. We are so excited to be here and to be part of this first event with the ICRN. We are the Ohio Valley ICRN chapter. So welcome everyone. Just a little bit about our chapter. We were a pilot chapter in 2015. We officially became a chapter in March of 2016. We were the second chapter of the IACRN. We're located in Cincinnati, Ohio. We have members from the tri-state area. Currently, we have a total of 45 members, so we're super excited about that. This is a slide that has where all of our members come from. So we have members from Cincinnati Children's, the Christ Hospital, CTI, OHC, Tri-Health, the VA, UC Health. So we have been able to collaborate with a large number of research nurses in our area, which is super exciting. We've been able to learn and collaborate and just to kind of learn each other's practice because we all do a little bit different in research. This is breaking news here in our area. Cicadas are coming. Take cover. Everyone kind of gets a little nervous when they're coming. They come every 17 years. They make a lot of noise. They're just a nuance. And we didn't know if everybody else was experiencing cicadas, but right now that is kind of taking over our area news. Everyone's talking about when are they going to emerge. They were supposed to emerge like a week ago. Now they're probably going to come this weekend. So everybody's kind of ramping up, getting ready for that. A little bit of information about cicadas. They live most of their time underground, which I think is kind of depressing. And they only come out every 17 years and they're only here for about a month, I think it is, or maybe a little over that. But everyone gets super nervous that they're coming and how they're going to plan for that. Another cute slide, just to give you a little insight. Fiona is a hippopotamus that was born at the Cincinnati Zoo in January 24th, 2017. She was the first Nile hippo imaged on ultrasound prenatally and the first born at the zoo in 75 years. So she's kind of a big deal here, kind of a celebrity. She's on ice cream, she's on shirts, she's on a lot of things. The other interesting piece with her is actually she was born prematurely and she was actually cared for by neonatologist teams here at Cincinnati Children's who helped provide some of her care. So we thought that was interesting to share. We also wanted to let you know sports teams that are in area. We have hockey, the Cincinnati Cyclones. We have soccer, which is very new professionally in our area, the FC Cincinnati. A lot of people are excited. They just got a new stadium. The Bengals are our professional football team, and the Reds are our professional baseball team. Who doesn't like talking about food? These are kind of our staples. If you come to Cincinnati or the tri-state area, everyone kind of knows Skyline Chili. Getting a 4-way, a 3-way, a coney. Grater's ice cream is also really popular. A lot of people will have that shipped to their home when they leave this area. Also, Skyline is something that people will buy when they come back to Cincinnati and then take it back to where they've moved to. Montgomery Inn is a really awesome place to get ribs, and a lot of people like to go there for a nice dinner.
Okay, and I'm just going to share a little more about the history of our region. We have and some interesting things that we have here. We have a vibrant cultural art scene, Music Hall, which is the big building that you see on that slide in the center. It's a classical performance hall in Cincinnati, Ohio, built in 1878. It serves as the home for the Cincinnati Ballet, Cincinnati Symphony Orchestra, and Cincinnati Opera. In 1975, it was recognized as a National Historic Landmark by the U.S. Department of the Interior for its distinctive Venetian Gothic architecture. We also have many theaters, museums, and beautiful parks to enjoy. Cincinnati's history is steeped in the brewing industry and pork, but I'll get to that a little bit later. The first commercial brewery was opened in 1812 By 1890, Cincinnati was the third largest producer of beer in the country, annually producing 4.2 barrels of beer per person and shipping it around the country, across the country and around the world. The economic powerhouse was primed by the city's excellent transportation options, fertile farmlands, and fueled by the large amount of German immigrants, who comprised over a quarter of the population by 1840. At one point, there were 45,000 people living in this neighborhood. Today, there are a little over 5,000. So it was a very populated area back in the day, and very crowded. By 1870, there were 36 breweries in the greater Cincinnati area. More than half of them were concentrated in a part of our city called Over the Rhine, which is one of the most historic districts we have in Cincinnati. When Prohibition came about in 1920, it ripped the life out of this community. But where there is beer, there are dreamers, and the beer industry is alive and well and thriving again. So breweries are popping up everywhere. We have nearly 60 breweries in the greater Cincinnati area, creating a great atmosphere for socializing with friends and family. Besides breweries, the revitalization of Over the Rhine includes many specialty boutiques for shopping and farm-to-table restaurants. Findlay Market, which is at the bottom of my slide, is Ohio's oldest continuously operated public market and one of Cincinnati's most cherished institutions. It is home to over 50 full-time merchants selling meat, fish, produce, flowers, cheese, bread, ethnic foods, and more. On weekends, the market hosts a thriving farmers market, a vibrant outdoor market, street performers, and several special events. We have many, many fabulous restaurants, and these are just a few of my favorites. Oops. There we go. Cincinnati was named as one of the 6 small cities with big food scenes, so there are options for every palate. We are also home to the Flying Pig Marathon, which was first run in 1999. It's a qualifying race for the Boston Marathon. Why a pig, you ask? Well, in the 1800s, when riverboats plied the Ohio River, Cincinnati was a center for Western commerce. Since agriculture was a prime source of revenue in this area, boats filled with livestock and produce would dock in Cincinnati to sell their wares. Today, Cincinnati is known as the Queen City, but in the 1800s, Cincinnati was Porkopolis, the largest pork-producing city in the world. The availability of pork byproducts brought other industries to the booming city, and small companies sprang up to process pork byproducts into soap and candles, including a little company called Procter & Gamble that has branched out quite a bit since its founding in 1837. We are also located about 90 minutes or so from the home of the Kentucky Derby, which was first held in 1875 at Churchill Downs in Louisville. It's the longest running sports event in the United States. And today, over 150,000 spectators gather annually on the first Saturday in May for what some refer to as the greatest 2 minutes in sports. Just recently, Medina Spirit was the winner this year. Besides betting on horses, Derby fans are famous for drinking mint juleps, singing Old Kentucky Home, and wearing flamboyant hats. Kentucky is also known for the Bourbon Trail. For more than 200 years, Kentucky's legendary distilleries have crafted the world's finest bourbons. You can experience the rich tradition and proud history of America's official native spirit road trip style as you visit the signature distilleries nestled among the most beautiful scenery the Bluegrass State has to offer. So if you ever have the chance, come visit us. There's lots of things to see and do.
And sorry, I apologize, we didn't do this in the beginning. I'm Crystal Hatter. I'm a research nurse at Cincinnati Children's Hospital, co-founder of the Ohio Valley IACRN. And this is Lori, my partner.
Hello, I'm a nurse at Cincinnati Children's Hospital. I've been here for over 30 years. So, and we both work in the Schubert Research Clinic. It's a clinic dedicated to research and is part of the Center for Clinical and Translational Science and Training. Young investigators can request funding for services in T1 through the CCTST. They also help support our chapter. When we were meeting in person, they would supply food for our meetings, and they help us with advertising as well. They've been a great support to us. We have industry and investigator-initiated studies in T1, and we have over 600 active studies. All research clinic staff can work on any of the studies, and our model currently is research protocol nurses who start up the studies, collaborate with study teams, and develop the orders using the protocol and other study documents. And our clinic staff follow the study orders performing tasks that are within their scope of practice.
And next, we want to show you a video about the Schubert Research Clinic. So it gives you a tour, also people who have used our clinic and our medical director, and also the head of the CCTST.
Welcome. The Schubert Research Clinic is a unique place to perform clinical and translational research across academic health center, including Cincinnati Children's Hospital, the University of Cincinnati, and community.
The Schubert Research Clinic is a portion of the CCTST, the Center for Clinical and Translational Science and Training. We have approximately 9 cores. This is the only core that actually specifically is involved with direct patient interaction.
We definitely form an amazing collaborating team with the nurses, and
We realize you can't see the video. We're working on that.
Thought I had figured it out where you guys could see it very easily through the video, like my PowerPoint, so I apologize. We'll start it over. Now can everyone see it?
Welcome. The Schubert Research Clinic is a unique place to perform clinical and translational research across academic health center, including Cincinnati Children's Hospital, the University of Cincinnati, and community.
The Schubert Research Clinic is a portion of the CCTST, the Center for Clinical and Translational Science and Training. We have approximately 9 cores. This is the only core that actually specifically is involved with direct patient interaction.
we definitely form an amazing collaborating team with the nurses and the coordinators and administration of the Schubert Clinic, because they help us prepare the orders.
One of the unique aspects of the Schubert Research Clinic is a combination doing pediatric studies and adult studies.
Hi, my name is Christy Crone. I'm a research nurse here in the Schubert Research Clinic. Our clinic is named after the late Dr. William Schubert, the second president and CEO of Cincinnati Children's and founding director of the Clinical Research Center. It started as a modest 8-bed inpatient unit. In 2015, it grew to be a state-of-the-art 27-bed outpatient unit devoted to the study and treatment of complex childhood and adult diseases. In 2019, we saw nearly 12,000 patients, logging more than 20,000 clinic hours. Our clinic offers a wide range of services designed to support clinical researchers. That includes nursing, bionutrition, sample processing and storage, and imaging. We have more than 600 protocols approved by the Institutional Review Board. Our studies range from high acuity visits, such as insulin clamp studies, to behavioral and observational studies. The bulk of our work includes investigational medication administration, pharmacokinetic studies, and sample collection. We see all types of clinical subspecialties. The ages of our participants range from newborn. We support the needs of any clinical researcher with a currently approved IRB study. Our staff is available for clinical research on any Cincinnati Children's inpatient unit or day clinic. We are accredited to participate in studies performed across the academic health center and community, including UC Health. Our nursing staff, which includes RNs, LPNs, and MAs, specializes in research nursing. We perform complex, detailed research observations and precise collection and storage of specimens. Our clinic has access to the Cincinnati Children's Code Team. Our rooms are fitted with emergency medical gases and suction. 7 of the 27 clinic rooms have continuous monitoring capabilities. Our investigational pharmacy, located directly above our unit, dispenses our study medication. We have 2 of our own medication rooms on our unit, and we have access to the Cincinnati Children's inpatient pharmacy. Our study participants have access to entertainment options such as TVs, iPads, and child life activities. In our bionutrition core, we incorporate nutrition assessment and studies. We collect dietary intake data and anthropometric measurements on research study participants. We also operate a metabolic research kitchen where we prepare food to research protocol specifications for feeding studies or food challenges. We also use the kitchen for general nutrition education and cooking demonstrations. In our imaging suite, we perform body composition imaging using dual energy X-ray absorptiometry or DEXA scans. Here we can measure bone density and body composition, including lean muscle mass and fat mass for the whole body or for specific regions. We are centrally located inside the Clinical Sciences Pavilion, also known as Location T. We are home to all study-related exams, assessments, imaging, and other tests.
Some of our trials go on for 2, 3, 4 years, and they become family friends. We always joke about one nurse who does cartwheels because one of our patients is in gymnastics, so they exchange the experience with gymnastics and cartwheels and makes her relaxed.
Thanks for joining us.
So that is our clinic where we, Lori and I work with other awesome research nurses and other staff. At this time, we just wanted to give you guys an opportunity to possibly ask questions about our clinic, about our chapter, about the area where we are, and just a little bit of a backstory about our clinic too. Before we moved to T1, we came from a unit that only had 5 beds to what we now have currently. So we are super excited to move into that space and to be able to offer it to all of the research professionals that utilize it. Just a second.
Thank you. I knew we could figure it out.
Yes.
Thank you. It's good that you hold the mute button, though, I think. So that's amazing. So how long have you been in that new space?
Almost 6 years.
Yeah.
Oh, wow. And how, I'm sorry if you said this, I was busy trying to write a tweet. I was very distracted. Tell me, how many nurses do you have working there with you?
We have 11 clinic nurses. We have 2 LPNs and 1 medical assistant that work in the clinic. And then we have 2 nurses who do the protocol nurse work
What does that mean?
and 3 research assistants.
What's the protocol? What's that protocol work?
Yeah, so I'm a protocol nurse. That's my role here in the clinic. And what I do is I get the protocol, I get all the study documents, I review those, I have meetings with the study team, and I devise physician order forms that the study utilizes to have those procedures that are needed at each of the visits. So if they need height, weight, that's put on the orders. If they need a medication administered, that's put on the orders. So myself and my colleague, we work with investigational pharmacy, we work with clinical lab, all the disciplines here at Children's to help facilitate that research and to make sure that the orders have everything that's needed. Once we develop those orders, they go to the study team to review and approve. And the study team is always the expert of their protocol. So they're always the ones that need to let us know when there's amendments, those type of things, and we make sure we get that updated on the orders. And then we send out an email to the clinic staff letting them know that there's a new study coming. This is who the PI is. This is the study team. This is what will happen at the visits. And then any education that needs to happen, special, different from what our clinical infusions are, research infusions, then we would help orchestrate that. And then the study's ready to go. So it's nice because it allows all of the clinic staff to work on all studies. There's not a primary. And so if we had primary nurses or primary staff, it would be impossible for them to schedule 600 study visits, all those different studies wanting to have their visits. So it allows for more flexibility.
Excellent. Thank you.
You're welcome. Thank you.
It's beautiful.
Thanks. We think so. Hold on. Sorry.
Thank you.
You're welcome. Hi, Gordon.
Oh, hold on.
Hold on. I muted you again.
Yeah,
Okay.
a couple of things. Could you said T1? I wasn't quite sure what that was, and also it's a fantastic facility you have there and great resources. And something that I'm really interested in working in a school of nursing is, do you have the possibility for any student nurses to come and have a clinical experience of some sort in the unit?
We have done that in the past. It's been a few years. So yes, we do have the ability to do that. We just have not had the opportunity to do it in recent years.
Okay.
And the T1 is our Schubert Research Clinic. We refer to it as T1. It's the location, the T building, first floor. So
Okay.
I apologize for.
No, it's fine. So sometimes you say things so often that they just become kind of
Yeah,
ingrained.
right.
Yeah, because I think one of the things that we found, we have quite a limited number of students who have the ability to have a placement in a facility similar to yours. But there's a real benefit for these guys, especially if they want to go on and have a career in research. And it really helps to spread the word amongst their student colleagues about about clinical research nursing, and raise it as a awareness as a career option. The other thing that we're trying to do is, when students are in a clinical placement, when they're working in a unit, if there is a research nurse associated with that unit, to try to encourage them to perhaps spend a day or even a couple of hours with the research nurse, just to find out a bit more about their role and find out about the work that they do. And I think that's been very beneficial, although it's quite difficult to organise because you're relying sometimes on the students, asking for that in the clinical area. But I think centralised clinical research units are ideal for that sort of thing, and it helps to kind of develop the next generation of clinical research nurses, because I think across the board, recruitment and retention of clinical research nurses is an issue, and these sorts of things can really help as well.
I would agree.
Yeah.
Thank you.
Yeah,
Thank you very much, though. Thank you.
Yeah, we used to have a summer intern program where students could come spend the summer with us.
Mm-hmm.
And I think we were so inundated, the hospital was so inundated with schools of nursing needing to get their clinicals, and students that are in nurse practitioner school are trying to get, their clinical hours in. So that program, I don't think, has been run for a few years now, but yeah, definitely. Yeah. Point well taken, for sure.
No. And absolutely. I think you can sometimes open the floodgates if you you kind of offer, because the schools of nursing are, especially just now, when I don't know about in the States, but over here, there were some students who took some time out during the kind of second wave of COVID. So those guys are catching up. So the need
Right.
for more placements is kind of going through the roof. But I think, it's obviously a fantastic unit that you work in and that you run. So I think the opportunity for students to have an experience would just be fantastic.
Mm-hmm. Yes, thank you.
Thank
That's
you.
one of the reasons I love the IACRN, because we get great tips from everybody, our colleagues.
Thank you.
Yes, thank you. Does anybody else have any other questions that they would like to know about the Schubert Research Clinic or the Ohio Valley chapter or our area or region where we reside? Okay, so we're gonna move on. And can everybody see my screen?
So our next session is a pre-recorded session. Julie Wijay Soria is the lead for the Research Participant Advisory Council, and she's going to tell us a little bit about what they do.
Hi, my name is Julie Wijay Soria, and I am the Research Community Liaison here at Cincinnati Children's Hospital, as well as with the CCTST, which is our Center for Clinical Translational Science.
Just 1 minute, I'm trying to make it bigger, so I apologize. I passed it, sorry.
Hi, my name is Julie Wijay Soria, and I am the Research Community Liaison here at Cincinnati Children's Hospital, as well as with the CCTST, which is our Center for Clinical Translational Science and Training, which is over University of Cincinnati as well as Cincinnati Children's. And I just first want to say thank you for the opportunity to share with you about our advisory groups at the IACRN conference. And today I'm going to talk to you about the power of the participant experience and how advisory groups can ensure that there is participant, patient, family, and community engagement. Voice research to help with our overall research process and health outcomes. So to get started, the objectives for today are that I can answer for you, what is a research participant advisory group? What was the process for setting up the groups? What are the similarities and differences between the two advisory groups? And what are some of the ways the advisory groups have helped improve the research participant experience and process? So to get started, what is a research participant advisory group? It is a relatively new and innovative approach to inform and how research is conducted, and it's modeled after the patient and family advisory councils. And this is very true. We collaborated with our patient and family advisory council to get ours started here at Cincinnati Children's. And what we know from patient and family advisory council's research is that when we bring patients, families together with healthcare staff, there's increased patient and provider satisfaction, as well as improved quality and safety of healthcare and lower costs. And the idea is that this cannot translate on the research side as well. And the core objective of the groups that we have, core objective is to provide a structured forum for research participants, family and/or community members to advise and engage with researchers across the academic health center on research practices at the center or in the community. And so now I'm going to tell you just kind of what the two groups are in general. We have the Research Participant Advisory Council, or we call it the RPAC. It was started in February of 2015. It's located at Cincinnati Children's, and it's focused on the overall participant experience at Cincinnati Children's. The second group we have is called the West End Community Research Advisory Board, and we call it either WeCRAB or WeCRAB. Sometimes I'll call it the Advisory Board. And it was started in June of 2016. And in this case, it's located actually at a community center in the West End, which is the red area you see in this map. It's located in a low-income neighborhood in the city of Cincinnati, close to the downtown section in Cincinnati, Ohio. And in this case, it's focused on community health and research. So getting started, how did this all come about? And it actually goes back to Becca Harper during her doctoral thesis, decided that she wanted to create the RPAC. She was the director of operations at Cincinnati Children's for our Schubert Research Clinic, which is a clinic devoted solely to research. And she saw a need for this. So she brought together staff, really a cross-section of hospital staff, to create a steering committee to help create the bylaws and the structure for the RPAC. And again, this involved anything from research nurses to our ethics and participant human subject research protections staff to also the patient and family advisory councils. And from there, they created, again, the bylaws, the structure, and then sent out a recruitment flyer, which is the blue flyer you see here, to invite everyone to attend meet and greets. And the meet and greets covered kind of what it means to participate in research and what the purpose would be of the RPAC and the structure. And from there, the first RPAC was formed. Then I joined the Children's Hospital in 2016 and took over the operation for the RPAC, and quickly met Melinda Butch-Kovacic, who was a member of the steering committee. And we started talking about the need for something like this out in community. And Melinda had already been very established in the West End community. And through that connection, we were able to go through the same steps of kind of creating the structure. We did the recruitment flyer you see on the left, and then had meet and greets talking about what research is and how this could tie to community. And from there formed our first West End Community Research Advisory Board. So I'm going to now tell you a little bit about each of the groups. The RPAC at Children's, we meet monthly. Before the pandemic, I should say, we met on site at Children's. We had food provided, transportation vouchers if needed. And right now we are meeting virtually instead. We have 21 members on the advisory council, and these consist of research participants, both pediatric and adult, as well as the parents and guardians of research participants, ranging in age from 14 to 66 years old. And we also do have staff representatives, content experts, and help with facilitation of focus groups if we have more discussions. So the objectives of this group are to provide guidance on how to improve research at Cincinnati Children's with a focus on the participant experience, establish best practices and improvement initiatives, humanize the face of research at the hospital, and then provide a formal referral system for other advisory councils across the institution looking to engage in research. And now I just want to give a couple examples of projects. And from this list, you're going to see both that we do institutional and divisional. The first is that we helped with our hospital-wide consent template when there was a new key information section added to the consent form. We helped with deciding what should be in that section and how it should look. We have worked with our infectious diseases division to create an assent template, as well, our consent document that has more visual aids and helps with the understanding for our adolescents 11 to 17 years old. We've also helped on how to approach for research. And this was in the inpatient setting, understanding both how and when to approach. And we did work with our Patient and Family Advisory Council on gathering the feedback for this particular project. We also helped to actually create and pilot an electronic screening tool so that our clinical research coordinators would not necessarily have to talk to every individual to screen, but instead, if there was a potential participant interested in a study, they can click on a link, fill out a screening, a few questions on a survey, and determine if they are actually qualified without having to try to schedule that phone call. So it's helped with being more efficient in research and making it more convenient to potential participants. We also help continuously with our hospital-wide biobank. everything from the consent process to all the recruitment and educational materials. We also even helped name it Discover Together Biobank. And then last but not least, we've helped continually with a human genetics study out of our genetics division with their videos, an online genetic results decision-making tool. We've done this with focus groups, feedback through online ways. Just we're always helping with that project that is ongoing, that study. So I'm going to tell you a little bit about the West End. We meet monthly as well. As you're going to see, it's very much structured in the same way as RPAC. We also provide food when in person. We're located again we actually meet in the West End at a neighborhood house, or at a community center that's called Seven Hills Neighborhood Houses. We're virtual at the moment. And in this case, there are 19 members that range in age from 14 to 75 years old. And we have 3 staff representatives. One is from Children's and one is from Seven Hills and myself. So the objectives here: humanize research conducted in the West End community and similar communities. Also to engage researchers to ensure they actually support the goals of the West End in terms of health goals, in addition to collecting their study data. And to this point, a lot of times what we hear in our communities is that researchers swoop in, their helicopters, they swoop in, take their information, and they leave again. And the idea of this advisory board is to create greater partnership, to move from research on and in to research with, where there's mutual benefits. Another objective is to provide opinions on how to make research easier and more understandable for West End community members in similar communities. So we'll spend time looking at the flyers, recruitment flyers, or the consent, and make sure that it's in terms that, in language that is understandable to the community, and guide what research happens in the West End. So we actually are trying to match up and make sure that the research that's happening has some benefit to the West End. And here's the last one, again, to say, make research more mutually beneficial, both to the participants and the community and the researchers. So the projects we have right now, we have multiple researchers that attend both the RPAC and the West End. We have, for instance, the Discover Together Biobank and the genomic study have both been to the RPAC and the West End. So we're always providing feedback to multiple researchers that are similar to the RPAC. And we have our researchers that are also going to be community specific on research that is more relevant to the West End community, such as heart health, stress in African American women in the community, cancer research, and mental health, for examples. In addition to doing feedback to researchers and community research, we are also always trying to get the pulse of the community. So we have done surveys now twice in the community on research and health needs, and that's helping us, or the West End Advisory Board, to better represent the community. We also have had research health days that actually showcase research happening in the West End. And we have ongoing partnerships. So now we have with 2 individuals. The first is Holly Jones, who is from our College of Nursing at the University of Cincinnati. And she is in the picture up in the upper right-hand corner. She came to us early on, before she even applied for her research for her grant, and asked how exactly we could partner. We actually came up with a written agreement of what the expectations would be of the advisory board, as well as Holly and the study. And she has now, since that time, gotten the grant. It's a K-01 grant called Be Swell. It's focused on stress in African American women. And we have helped her with creating the modules for the study, the recruitment for the study, and are actually also helping with the actual facilitation of the study at this point in time. And then the other one is actually with Melinda Butch-Kovacic, who got a Science Education Partnership Award called We Engage for Health. And this is around health literacy and really almost like a citizen science approach we have been able to help create the characters for a series of stories that talk about everything from nutrition to heart health to obviously around COVID-19, that along every step of the way, we've helped create the characters. We've voiced some of the characters, and now individuals are actually helping. Individual members are helping with the facilitation of sessions associated with this project. So I wanted to just take a step back and say, okay, so what is it that advisory groups help with? Well, they help provide input with and feedback and ideas and guidance on anything from research study design and procedures to strategies and recruitment strategies and methods, recruitment materials, consent and assent forms, education materials, survey, interview materials and content, websites, smartphone apps, and really honestly anything that is going to be community, patient, participant facing. We can help with to make sure that it's done in a way that will work best with the community or the patients and participants. And how do we give this input? We do it through whole group and small group discussions, individual interviews and written evaluations, focus groups, and some of those I actually will end up recruiting non-member participants. For instance, on the left-hand side, that is our genomics focus group, where we brought in additional 18 to 21-year-olds to help give feedback on the particular genetic test results tool that they wanted to see how the younger population responded to it. We also give formal feedback to IRB protocols. We are individual advisors on projects and study teams. Sometimes I'll find additional patient or participants to help with this. But these are like PCORI grants or quality improvement grants. We do remote electronic review forms and surveys. So we don't always have to meet in person, but we can do things remotely as well. And we've helped with role-playing scenarios, which is on the right-hand side where we're helping with a phone script, doing a role play and kind of helping improve the phone script for a community research project. So the other component I wanted to share with you is that our advisory groups also are involved in education and capacity building training that is beneficial to them. So all members receive human subject research ethics training. And as the visual here shows, we start with like, what are the human research abuse history moments over time, as well as the regulations. And we talk about just what's in place. We talk about the IRB. We talk about really that all researchers have to go through city training. We go through a little bit of the research process. Also, all our members have been able to participate in field trips to research facilities like our biobank. That lower picture is us doing an experiment at the biobank on extracting DNA from wheat germ. And we also bring in guest educational speakers. And most recently we had a guest speaker from Case Western who was an expert in international genomics biobanks. And then specific to our West End Community Research Advisory Board, we have something called the Community Leaders Institute that we'll encourage our members to attend. We also have created a community resource finder that's at the center, that before COVID, they could come in, they could always look back at past notes and presenters and kind of have it as a reference document. And then some of our members are now becoming community research advocates as part of the We Engage for Health project, where they're really helping to get the word out in the community in a very targeted way. So last, I wanted to just share with you what we're doing during COVID-19, during this past year in the pandemic. Definitely changed the way we met, and some of it was just ramping up on how to do virtual meetings and what this would look like. But we quickly got involved with our COVID-19 vaccine studies to help with outreach and targeted recruitment, and with the goal of ensuring that we had a diverse population. And both groups were helping with like attitudes and concerns towards the vaccine trials, messaging in the community, barriers and myths that we were hearing. And we also had group feedback on flyers and other recruitment materials that were then used out in the community and to message across the hospital. Specifically for the RPAC, we also got involved with a COVID-19 social distancing behavior study. And we were very involved with the survey development for this, as well as helping to pilot test their focus group scripts and really kind of how their focus groups would run. For the West End Advisory Board, first, I would say we did help with that same social distancing behavior study. But in this case, we looked at this, we did survey review, and then we actually helped to conduct surveys out in the community to ensure we had a more diverse respondent pool than we were seeing without their help. So they were extremely helpful in ensuring we were having a more broad and diverse voice response. But also at the very beginning, we sent out care packages with masks and hand sanitizer, COVID-19 information, and actually that we engaged for health stories that were about COVID-19 to help our advisory boards get the message out into the community. And the last thing I would mention is that we're involved in a year-long collaboration with our clinical research professionals group here at Cincinnati Children's, really focused on biases in research and health-related disparities, and helping there to be bidirectional communication and understanding of what it means to work out in community and do community research. So the last thing I just wanted to share was, in all of this, we started with the idea that this is modeled after the patient and family advisory councils and how we've seen results there, and what are the benefits then if we're doing this on the research side. And if you look at this as, you know, advisory members and researchers, on the advisory member side, there's education, capacity building, trust, community resources, engagement and health advocacy. And then on the researchers side, you're helping with all elements of the research, the study design and implementation, consent forms and process, better recruitment process and materials. And really, it is about humanizing the research experience that otherwise may not be available to researchers. And then in the middle, we have the bidirectional benefits. And this is just the fact that there's an understanding both ways of each other's perspectives, challenges, limitations, and motivations, which can only improve how research is done and improve really community and individuals' participant experience in research. Communication and trust increase, as well as the connections and the relationships. And the last thing I wanted to leave you with is two examples of how this actually plays out on an individual level. And the first is I have a board member, Camilla Kesey, who is on my RPAC, who had not participated in research I have a couple of these members that have not participated in research, are curious, and have been on the board to kind of lend their perspective to everything. And when we started the phase 1 Pfizer COVID-19 vaccine trial, she stepped forward as one of only 40-something individuals in the community in Cincinnati, and one of only 2 non-whites in the study. And she said she did it because she understands research a lot better now, and that she wanted to be an example for her community. So that's how it can impact on an individual level. And we've seen growth in understanding of research on that individual advisory board member level. And then the other side is I have the example with Tiffany Grant, who was a collaborator researcher with our West End Community Research Advisory Board. She came to us when she was going to be putting in a grant to bring a information kiosk to the West End community. And we talked about the need for also a blood pressure kiosk. And she was able to write that into the grant. And we were able to bring a blood pressure kiosk to the community center that anyone in the community can use. So these are just 2 examples of how the advisory groups can benefit on multiple levels, both individual and community researchers, And hopefully this is helpful to you to understand why advisory groups can be helpful in the research setting. Thank you again for your time, and I am happy to answer any questions if you have them. You can feel free to email me after this presentation. Thank you very much.
So we are excited. We have Julie actually here with us, so she is available to answer any questions that any of you may have. And Julie, thank you so much for your presentation.
Hi, Crystal. Yes, you're welcome. I think Elise Peterson was raising her hand. I think.
Yeah, I just
Yes.
unmuted her. Sorry.
Okay.
So thank you, Julie, for this. This is I think this is a well-needed add-on to research. My question is the input of the participants. Is it an equal voice, or is it can the participants sometimes have a stronger voice than the researchers, or how does that voice work?
Good question. I would say it's a little bit different on each of the advisory groups I have. I would say for the RPAC, the Research Participant Advisory Council, I would say it's more researcher driven with questions and participants are giving their responses. With the West End Community Research Advisory Board, there's more of a concerted effort to have it be more community-based, participatory research and model, like the model of how we have it. So it's more about voicing the needs of the community and trying to bring that to the researchers and actually mold what kind of research is happening and how it's happening in the community. So I think there's a little bit of a different flavor for each of them. The one hospital-based is there's not, and I would say maybe that is because one is neighborhood-based. It's a group of people who identify with a community, where the one at the hospital is a little more broad-based, running across, it's a cross-section of research that varies broadly, and in terms of disease type or healthy individuals or adults or youth. So I don't think there's that cohesive, identifiable, group as much. So yeah, I think each is a little bit different. I hope that helps answer that question.
It does. Thank you. Thank you very much.
Hi, Gordon.
Hi, Julie. Thank you very much, Crystal. Julie, that was really interesting, and I think it's a really great example of how you can almost have co-production of research, and because I think a lot of times the participants and patients themselves can get left behind a bit in terms of the infrastructure and also the questions that are being asked. So it's a really fantastic opportunity that you've developed there. I was just wondering, is this a national kind of movement in the States, or is it how widespread are these groups, or are you guys the innovators?
I actually don't know of any other advisory councils that are, it's not I don't know how nationwide it is. Let me just start there. I do know that for instance, one group we have is a collaborative group around genomics between 3 hospitals, and we're making sure there's a patient family voice, participant voice. But yeah, it's something I've been meaning to look into. I'll leave it there. I'm not too sure how widespread it is.
Because I mean, my next suggestion really, I guess, is have you looked into publishing? Obviously this is from the conference last year, but have you looked into publishing the work that you've been doing? Because I think there'll be lots of groups all over the world that'd be really interested to find out about the work you're doing and how they can implement that locally.
Yes, that is on the horizon. I don't know if Crystal, I don't know if the poster was shared. I did present a poster actually at our public responsibility and medical research primer conference, which is around human subject research. But yes, the next step would be I am working on publishing. Thank you.
Okay, thank you.
Any other questions? Okay, well, thank you so much, Julie. We really appreciate you sharing about the RPAC, and it definitely has made a difference here at Children's with the research, and I think with the research participants feeling like they have a voice, right? We want them to feel like they're part of that process. So thank you so much. I will have Julie's contact information on the last slide. If you want to reach out to her later with questions, you can email her.
Thank you very much, Crystal, for having me.
Yeah, thank you. Can everybody see my screen? Okay, so as we all know, COVID has really affected all of us across the world. It came in unexpectedly. It affected our daily lives. The nursing profession and healthcare was affected. We really had to figure out what we were going to do. During the pandemic, nursing as a profession was showcased, and research as well. Research is a key reason why we are seeing a light at the end of this time in history. The next two presenters that we have as part of this presentation will show how we address the needs of our local community during COVID. So that first presenter that we will have presenting about COVID and how it was managed in our area is Michelle Dickey. She is the clinical director of research at the Gamble program. She has organized and implemented COVID trials and been part of the Operation Warp Speed. She probably has not rested or had a moment of break since COVID happened. And I am going to share her presentation that she gave at our clinical research professionals. So there will be just a moment of lag while I'm getting that set up. And we also have Michelle who will be here for questions as well.
About the COVID-19 pandemic and the impact on clinical research. In full disclosure, I have no financial disclosures or conflicts of interest for my presentation today. However, I do direct clinical research and work as a sub-investigator on COVID-19 vaccine trials, currently for Pfizer, AstraZeneca, and Moderna. Our objectives for today, I would like to discuss the immediate impact of COVID-19 on our clinical research processes, and then some adaptive measures that we developed in response to the stay-home orders. And then lastly, I'd like to end with some innovative processes that we created to maintain our current research while starting on this incredible journey to rapidly enroll participants into high-priority COVID-19 trials during a pandemic. So I thought we'd start by going back a year. So just over a year ago, we had our first case in the US. Shortly after that, we had our first death. Also, the NIH announced the first trials on remdesivir, our first treatment. If you look, March 13th is when the COVID pandemic was named a national emergency. So we're just about a year away from that. And then a couple of days later, the NIH started their first COVID-19 vaccine trial. And around this time is when we knew that our life was going to seriously change in the research world. I also highlighted that the government lifted constraints on telemedicine policies, which certainly made our lives better in research because before this time, telemedicine or telehealth, virtual research visits were really not very much in our vocabulary. So shortly after that, as you all know, the world temporarily closed. And we in Ohio received our shutdown orders on March the 24th. So the immediate impact of that is we were told not to enroll any new subjects unless it affected their clinical care or it could be done remotely. I'm sure all of you are in the middle of research trials. Some were starting research trials, some were close to ending trials. So this was quite a scramble to figure out exactly what to do. And as I previously mentioned, we all needed to go remote, but we really didn't have systems for that. We were asked not to tap into the telehealth system for clinical care because they assumed that would all be overwhelmed, which I'm sure that it was. And we are encouraged to use private tools like FaceTime or Skype, but also trying to maintain privacy. So this was all pretty much of a challenge. Our external monitoring and auditing was halted, which part of that probably sent up cheers for many people. But then there's also the flip side of that for how are we going to accommodate this? Do we have the right systems? And then our basic science was placed on hold. For our observational, non-interventional natural history studies, these really were just put on hold unless those studies could be done by the clinical providers. Those studies that had greater than minimal risk or interventional, such as drugs, devices, and biologics, were allowed to continue, but only if subject safety was at risk or if failing to see the subject and have them come in for their visit would make their data non-evaluable. And then, of course, COVID-19 research was allowed to move forward. But this research had to go through a special COVID research committee and be approved before you could proceed. So for those studies that were able to continue to see participants, there were some guardrails. Participants had to be informed of the potential risk if they decided to come to the clinic. And then we also had to pre-screen them before they came to the clinic and then upon arrival to the clinic. So this added an extra layer, not just reminding a person of their visit, but also to make sure that they were healthy and qualified to be here. So for our program, as you can see, we had quite a few vaccine trials ongoing at the time of the shutdown. We had participants who were in active vaccine phase, safety follow-up, and some were actually approaching the end of the study visit. So we needed to reach out to the NIH and our other sponsors to ask for permission to have protocol deviations both for out-of-window vaccines, for follow-up visits, and one study we actually terminated early. It was very close to closing out, and so we were allowed to just end that study. We also, as I mentioned, had to put in procedures for that COVID screening and then informing participants of their risk. And then because we were in a rush to consolidate much of this, we had to coordinate with the pharmacy and lab to make sure that they could also accommodate the rescheduling of all of these existing study activities. So in March and April, we were really focused on much of the things that I'm sure you were all focused on. PPE, how to social distance, where do we get signs, how to get them up, where to put them. For our clinic, we went from 5 days a week, consolidating people down to 3 days a week, and then 2 days a week, and then 1 day a week. And this was over 2 to 3 months because we had a really large volume of people, and it took us a while to be able to collapse them down into that 1 day a week. And that included, again, but not just the clinical piece, but the lab and the pharmacy. And then if we were going to retreat into a remote world, how do we do that? And everyone didn't have a laptop. Everyone didn't have a headset. We didn't have remote calling from our computers so that we could talk with our participants. We really didn't have systems for virtual visits. Thankfully, about a year ago, we did move to electronic systems for almost everything in our department. We had a few little pieces of pending paper left, but really just thinking about how to move all that, how to move your documentation, how to move all your communication systems to electronic, and then what to do with your study monitors. Well, most of our monitoring pieces are remote. There are still pieces, the reg file, that needed to be shared, and how would we share that, and how would we share documents? So those are all big challenges, and I think overall we conquered most of these at this point. So as we were closing out these other studies, we also really had to start preparing for the pandemic. And I like to say this is the big one. I've been preparing for this one for my whole career. I was hoping to make it to retirement before it actually came, but I didn't quite squeak out of here. So here it is, it's here, and we're in the midst of it. We're infectious disease, and we're doing vaccine studies, and we're having to get ready to go. So Moderna started their first trial in March, on the 16th of March. And then in April, the NIH created this group, ACTIVE, Accelerating COVID Therapeutics and Interventions in Vaccine. And then May, Operation Warp Speed was created. And these groups were all created to develop public-private partnerships to coordinate research, and then also to have a funding mechanism to invest in the coordination, manufacturing, distribution of diagnostic therapeutics and vaccines. In our branch, the National Institutes of Allergy and Infectious Diseases was certainly right in the midst of that. I'm sure all of you have seen and heard Dr. Fauci at this point. And we are part of this group called the Infectious Diseases Clinical Research Consortium, also the Vaccine Treatment Evaluation Unit for the NIH. So our group was right in the midst of all of this planning. So during this process, the NIH developed these strategic plans for COVID research. And one of those was to improve knowledge, for testing, to advance treatment, therapeutics, prevention, vaccines, transmission, and then also to look at health disparities in vulnerable populations. So I just wanted to post this because while certainly we are in the midst of this, these categories really cross all areas of your research as well. And so I believe that all of you are doing COVID research or will be doing COVID research because these strategies are quite broad. I also wanted to mention Operation Warp Speed. which is this accelerated vaccine process. In our conversations with the community, which I'll talk about in a bit, I think this has created a lot of fear in the community because they're afraid if you go fast, you're skipping steps. And you can see here in the graph that they really just collapsed the activities. And I can assure you from the clinical's perspective, we have done the studies exactly the same way we've always done them. We recruit the participants, they come in, they're screened, they're assumed to be eligible, they're consented, of course, and their specimens are drawn and their data is entered, and they continue to come back just as always. The things that are very different are the data has to go in that day or within 24 hours. And there's pretty close to 24-hour monitoring. So someone is always in that data, looking at that data, querying the data, and expecting us to respond to those queries and clean that data up as soon as possible. The other pieces that are unique are the lab specimens aren't batched and shipped every 2 to 3 months or 6 months or whatever a routine study would do. Those specimens go out that day, the next day, and the sponsors are running all those specimens in real time. So all of these processes are overlapping. The other piece is these sponsors started developing vaccines before the first trials even began. They had the permission and the funding to go forward. And so typically you would not just manufacture a vaccine until you knew that it worked, it was safe, and it was approved to move forward. And so those have been the collapse of those pieces. And I do think that has helped when talking with communities to really let them know these pieces. So I wanted to share that with you so that if you had a chance to talk about that as well, you could. So the immediate impact on us in March, as we are closing out or trying to finish off other clinical research studies, we were approached by Pfizer to participate in their phase 1 and then phase 2 and 3 trials. And then also with our NIH grant, we were told that we would be doing phase 3 trials for the NIH. The plan was that we would have 3 to 5 COVID trials. They would run consecutively, and we would be expected to enroll 500 people over 8 weeks back to back to back. And so if you look at those numbers, those are thousands of people. And our typical clinic day, a busy clinic day, would be about 30 people in a day. So this certainly takes us 50, 60, 100 people a day. Once you enroll these people into the study, they come back in 21 days or 29 days, depending on which vaccine it is. So you can see these numbers continue to double and quadruple over time. Another little factor are that everyone enrolled in the trials are followed for COVID-like illnesses for up to 2 years. So for some studies, they are able to contact the site and start self-swabbing and shipping those in. For other studies, they actually have to be on site, seen on site and swabbed and checked out by an investigator. So this is all quite a large amount of work and doing things that we really had never done before. To this, I should say, to this magnitude. So one of the first things that happened is we got 5 pallets of PPE, which was great because a lot of people were worried about getting PPE. But as you can see, it's a lot. So what do you do with that? While we don't have the luxury of a new building at Oak, we do have the luxury of space. So, but even for us, this PPE is quite overwhelming. I think we now have probably 4 rooms because they just continue to send pallets as a new study starts. So if anyone ever runs out of PPE, we probably could lend you a hand. So what about the facilities? We have an outpatient clinic and an inpatient clinic here on the Oak campus. And typically we run our studies just in that inpatient unit. However, because of the volumes looking to go from 50 to 100 people a day, it would be very difficult to maintain social distancing. Even in the, the nurses station, I call it because I'm an old nurse. But even in that area, was very hard for the staff to keep distance. So we actually had to open up both of our clinical units to be able to accommodate the trials. And just finding space for everything, the supplies, the tubes, the kits, the PPEs, and getting signage up everywhere. The community at this point is quite used to all the signs and the stickers and the plexiglass. And so they are expecting to see that when they come to the clinic. So trying to get that up to customer expectations. And then just, equipment. As I mentioned before, everyone didn't have a laptop. We didn't have enough computers. We had a handful of WOWs, a few iPads. We couldn't take everyone to the triage room back to back to back to back to get weighed and measured. And so we actually ended up ordering stickers for stadiometer stickers for the clinic that are next to all the doors. And we actually didn't have vital sign machines with O2 monitors. I know you probably do at main campus, but clearly for a COVID trial, O2 saturation is important. So we needed to get this kind of equipment. And so this was quite a large task to undertake. We also had to get budgets and contracts pushed through quite rapidly. And then just purchasing all of these things. I've been here a very long time in research. Sometimes, as you know, getting things you need in research is a little bit harder. And so I like to joke with my staff that I somehow stumbled over the magic COVID 8-ball, because over this whole period of time, no matter what I've needed or asked for, the answer has just somehow always been yes. And it's been a truly amazing year. And I'm sure it's soon to end, but I've certainly enjoyed that part of the year of having my magic COVID 8-ball. Everyone has been quite accommodating. We needed more check-in stations and tables and iPads and computers, and folks in purchasing have really just helped and pushed all of that through, and it's been really great. I mentioned earlier about electronic systems, documentation, communication, study monitoring. Really, we had invested a lot of our efforts into REDCap, and so we've moved most everything into REDCap at this point. And this has been tremendous. And I do believe we can help people going forward with all the things that we've done for communication. And then what about personnel? At the time the studies were set to start, I had about 25 staff members, included nurses, about 10 nurses, 5 CRCs, 1 data person, 1 recruiter that also did the vaccines, our administrative staff, our budget staff. At this point in time, certainly, how do you find enough people to see 90 to 100 clinic visits a day? Enrollment visits take up to 3 hours. Where do you find them? If you find them, where do they sit? How many do you need? How do you get them trained? All of these studies have, I think the AstraZeneca trial had probably 25 or 30 modules to do. Plus, as you know, if we bring in people who are not research nurses, they have to do city training and all of the other things for research. And so certainly administration has been wonderful. I'm sure they're glad I haven't emailed them in a couple months, but I just started reaching out and saying, if anyone's on furlough or anyone doesn't have enough to do, I will take them. I need them. Please send them my way. And so they actually did that for us, and we've been very blessed in that way. So we were sent clinical staff from the PICU, from the CICU, Schubert and OCTR have also sent clinical research nurses and CRCs to augment our team. And I just thought I would share pictures with you of all the activities that have been going on here in our department. As I mentioned, we had just one recruitment coordinator who also doubled as the unblinded vaccinator. So certainly I don't think that she could have handled the volume that we had. And so we were lucky enough to be able to bring on a couple people through ANC that you might recognize, Jill and Joan. And then also the Schubert Research Center jumped in and helped us with recruitment. And I'll talk about that a little bit more in a bit. And then data coordination and coordination of all these activities. As I mentioned, we had one full-time data person, and I'm not really sure how they would even attempt to enter that many charts in one day. And so just building that data team, which again, the institution helped provide data coordinators, data entry folks from across the institution. And then we also had one full-time data support person manager who is responsible for building and creating all these REDCap databases. And so I'm not sure she's stopped working for a single minute since March, but we have also been able to build that team as well over time. The pharmacy as well, our pharmacists typically give 10, not more than 20 vaccines in a day. And so looking to ramp up to 60 vaccines. The Pfizer vaccines are quite complex in mixing. Everything has to be verified by a second person, mixed under the hood. There's many, I think for some studies, there's at least 5 pieces of paper that needed to be completed. So how are we going to do this? So we actually created a team of nurses who are able to help with this process. They're both blinded and unblinded vaccinators. And I think we have a team of about 10 people now, also added another pharmacist. I wanted to mention the Laboratory for Specialized Clinical Studies, which is the infectious disease research lab here at Oak that work with us. Not only did they jump in and work on the trials, but their team also developed the first COVID PCR test that was used by Children's for both patients and employees up until Children's got their test running. They also developed a COVID antibody test. And beyond our group here at the Gamble, they also support other COVID studies across the institution. So they're quite busy as well. And not to mention, last but not least, I guess, the investigators. Dr. Frank is our director. Typically, we would have Kristen Bushley or I, who are the nurse practitioners, would be here at clinic to help cover the clinic every day. And then we would have other investigators that join in on the clinic coverage. However, we've really needed 2 or 3 people here every day. So this has been quite interesting and challenging. So recruitment of thousands of people, this is certainly something I've never done in my career. We needed them to be 18 to 85, and then we moved down into the younger age groups. In the beginning, we were looking for healthy people, and then we moved on to people who are more at risk for COVID disease. And certainly we wanted to have a diverse population. We talked with marketing and media. We sent out messages through MyChart. And we also tapped into this national COVID registry that was available through the NIH. And many of you have probably seen these ads on your Facebook page. They pop up most every day. However, another unusual thing in my career, really for advertising for this study, we sent out this one simple flyer, pretty vague, just asking if people would be interested in joining a study. We sent it out on Outlook in April. We said, please share this with your friends and family. And within about an hour, we had 2,000 people who e-screened for the study. So that's never happened to me before. Once this went out to friends and family and hit the news, within about half a day, that list was up to 4,000 to 5,000 people. Unfortunately, the list of interest was not very diverse. I would say it had less than 5% diversity. And goals for these projects, as you know, are to be sure that we include diversity. So I'm a member of the Research Participant Advisory Council. So one of the first things I did is reached out to Julie to get input and help. The RPAC, for those of you that don't know, is there for all of us. They partner with the participants and family and also the community to help improve research, the participant experiences, to build trust, create best practices. They'll also form a referral system for you if you need it. Truly one of the things that I think they've done great work at is humanizing the face of research. And then they also provide this infrastructure to include patients and family and research study and design. And our group has used the RPAC quite a bit to help us down the right track for advertisements, for developing electronic consenting. And so I highly recommend this group if you've never interacted with them before, for you to participate with them. So we knew very early on that the Blacks, Hispanics, and Native American communities were being the hardest hit from COVID-19, not only serious illness, hospitalizations, but also death. But historically, African Americans, while they represent 13% of the population, they only represent about 5% of clinical trials, and Hispanics, 18% of the population, but less than 1% of the clinical trials. So we knew that we really had our work cut out for ourselves to try to ensure that we got diversity in our trials. So through the RPAC, we are allowed to come and present our studies in general and our advertisements to the RPAC group. And we ask them about attitudes and concerns, just how the general messaging should be in the community, and identifying barriers and myths. They looked at our flyers, and they really actually had lots of great comments. Thinking back to that time, most people on the RPAC committees, of which there's two, I forgot to mention, there's a group at the main hospital and also at the West End group. Thinking back to that time, most people were very hesitant to get a vaccine. There were very few people in the group that raised their hand and said they would be the first volunteers, and they were really wanting more information. They did let us know they don't like stock photos. They really felt the photos in our flyers should represent the community. And they actually gave creative input into the flyers so that we were messaging more directly to the communities that we were looking for. We did actually have one of our RPAC members, Camilla here, who joined the phase 1 of the study. She was in the first 44 participants, and we also have 4 more of the RPAC members that signed up at later phases. And so we felt like this would be great for her to be able to help us reach out to the community and let people know that the study, her experiences with the study. Julie also connected us with the CCTST Community Engagement Corps, and the Engagement Corps is there to improve health outcomes and eliminate health inequities. And we, Lori Crosby, Monica Mitchell, and Farah jumped in right away, and we're eager and enthusiastic to help us with our recruitment activities. So we immediately began to develop collaborative strategies. They helped us identify community partners and build relationships. We began to invest in time and listening and understanding the community concerns. Dr. Frank, Margot Moore, and I joined in on an every other week community call. We were tapped into many community groups through churches, community centers, through various health leaders, parent groups. We even jumped in and went to a farmer's market. So we did quite a lot of community events, and of course all remote with the headphones. Here's a picture of Dr. Frank in one of those early groups, which was the beginning of our remote community activity processes. We worked to develop community-based strategies with the CCTST, and they helped us develop community champions who have been assisting us all through the process to get the word out. Not just about joining studies, but about COVID in general, education, and vaccine safety. So here's an example of a flyer that the RPAC worked on with the CCTST, which if you've been at Children's a while, you know this looks quite different than our typical flyer. They felt it was very important to make in bold that the vaccine will not cause you to get COVID-19. And they wanted the language to really be around the community and the culture. The three things they really wanted to know about was what are the procedures, how much will I get paid, and what's my time commitment. And they really wanted to stress the common side effects. They felt like this was important to know. They didn't want to sign up for anything if they didn't know what the side effects were going to be. And so this is one of the flyers that we came up with for the community. And as you can see, we also worked on getting photos that were more representative of our community populations as well. And here's one of the innovations from this process. We developed a photo bank of participants, volunteers. Many of these might be people that you know, but the RPAC, the CCTST, our community, friends, family joined in and helped us develop a photo bank of different community members so that when we do have flyers and outreach, we have photos that are representative of those communities. And I think this has been a great outcome of this project. Dr. Frank has actually gone on from those first community events to be quite famous or infamous, depending on how you want to say it, going national and even now having his own YouTube cartoon about COVID-19 vaccines. So I think these some of these innovations will be long lasting. They're platforms to build on for the future. So just to talk a little bit about some of the other things that we've done, screening of participants. How do you screen 4,000 people and figure out if they're eligible to be in your trial? First, healthy, and then they need to have comorbid conditions for COVID. And so we already had an e-screening project in REDCap where we sent people to screen for our studies. And so we really just built on this and we fleshed it out. We talked with Jeremy Korsmo and ORCRA to try to make sure we paralleled other COVID registries in the institution so that at some point, if we needed parallel information, we could do that. And so everyone was funneled through this e-screening link, and that has worked out very well for us. As part of that process, we also attached the consents, study handouts with the procedures. We had a video consent as well, and we developed a ClinCard video so that when they came to clinic, they already knew about the ClinCard and how it worked and what that system was going to be like. Just trying to cut down that 15 minutes or so you would spend with somebody to talk about ClinCard. We also had to develop that remote recruitment team because we did have to call everyone and just verify that they qualified before we brought them into the clinic. If you're having 50 or 60 people come to the clinic every day, you don't really want any of those to screen fail. So how do you schedule all these people? Certainly that was a huge task. And shortly before this, the institution had moved to self-scheduling through the web for some of the satellite clinics, the emergency rooms. And so I reached out to this team. I don't know that this has ever been done for research, but certainly they were enthusiastic and jumped right on this and helped us develop some self-scheduling websites for our vaccine visits. So we've been using this for the first visits to get folks in. It's worked wonderfully well. I'm hoping that this is an innovation that lasts beyond the COVID studies because it's been terrific. We've had a couple snafus where parents have figured out they could schedule more than one kid. So we ended up with 86 kids on the schedule instead of 60. So it's not quite perfect yet, but it's been a tremendous access. Of course, safety in the clinic and the COVID screening has been a challenge, I think, for everyone. Now that that's on the kiosk, that's been very helpful. Having communication, remote communication, and much of our communication in REDCap has been a great asset to us. At the time that we started, we had no kiosk at the Oak campus. Everyone came to the front desk to check in, and that just is not possible with 90 people in the clinic. So we were able to get a couple mobile check-in stations, and we were also given mobile check-in Microsoft tablets to be able to set up about 10 extra mobile check-in stations, which has been tremendous. Just little things that you don't think about is getting stylists in a pandemic. Everybody needs to use a stylist to keep things clean, and everybody in the world was looking for those. So we were out having to wipe down our stylists every 20 or 30 minutes because we ran out of stylists. For consenting, this process, we are able to develop consent videos. The institution helped us with that, and this was also very helpful. We were able to show those videos to the participants when they came in and then complete the consenting process with them. We got a lot of positive feedback on the consent videos, and so that's also something we would like to continue. And really just process and procedures, having a lot of new nurses that had never done research procedures before, or did different kind of more complex procedures, but not phlebotomy or nasal swabs or collecting saliva. So doing all that training was also fun and challenging as well. How to vaccinate more than 60 people a day is a huge challenge. I think we've conquered it. It's quite overwhelming, but as I mentioned, we do now have that core group of about 10 folks working to vaccinate. Some days that's a challenge for where to put everyone. And as I mentioned, our visits could be up to 3 hours long. Not just us, but the lab also has to process and ship all those specimens. In the mix of all this, we've had about 60 COVID-like illness visits on campus, as well as those virtual visits for the other study where they do self-swabbing. And this will continue for us for about another year. Electronic documentation has been huge. I'm very thankful that we moved in this direction before COVID. It would have been quite hard to convert all of this to electronic at one time. Little quirky things like people who don't have an iPhone who want to join a study need one. And so Children's was very helpful in getting us iPhones for our diary apps. We had to set up Uber and rideshare because we needed everyone to be able to get to their visit. And if you're going to recruit from the community with folks that might not have cars, we need to make sure that they can get here. We've also talked about using the mobile clinic, and that's still something that we think that we'll try to do for the next study that starts in the spring. One of the most things that I feel proud about, and I'm hopeful that this translates, is I feel like we've been given the opportunity to spark interest and provide training for the next generation of research nurses and research coordinators. As Peggy mentioned, we're on the downslope of our careers here, and we certainly want to see a new group of nurses come in and fill these gaps behind us. And so we've had, I'm guessing about 15 nurses from the PICU and the CICU who've been over to help us. And so someday in the future, hopefully some of these will have enjoyed their time here and will find research as interesting and as amazing as the rest of us do, and they'll come back to us. So I'd like to just wrap up real quickly about the vaccines. since this is the impetus of all of this. So currently we have 5 different platforms that are being looked at for developing vaccines. The inactivated or live virus vaccines are not being done here in the U.S. The viral vector vaccines we have are AstraZeneca and the Johnson & Johnson. Johnson & Johnson, I'm guessing, will be out for emergency use authorization toward the end of February next week. AstraZeneca is preparing to submit theirs as well. We have, of course, have the RNA vaccines that are already out for emergency use authorization, Moderna and Pfizer. And then there's a couple more, the protein subunits that are in study and will be coming down the pike soon. And those are the Novavax and the Sanofi GSK. So currently the trials we've done here at Children's, we've worked with both Pfizer and AstraZeneca at this point. We were one of 4 sites in the world to do the phase 1 trials for Pfizer and one of 5 to do the adolescent phase 2 trials for Pfizer. We also did the phase 3 trial for AstraZeneca, and currently we have over 1,200 people enrolled in these studies since July. So it's been quite busy here. As I mentioned, they all come back to get their second vaccine. So everything doubles and quadruples over time. Future studies, we'll certainly have more adult studies coming and more pediatric studies. Our pediatric studies have gone down to 12 at this point, 12 years, but we expect them to go down to 5 years and maybe even to 6 months or 2 months within the year. We have studies coming for pregnant women. There are stability studies for the different vaccines. They may do dose ranging studies to look for different doses. In March, we'll start a COVID vaccine study for the variant strains, so at least one of those. So there's probably more of those to come. And then toward the fall, there'll be 2nd generation vaccines. One of those being developed here by Dr. Spearman is a COVID nasal spray vaccine. Like all good researchers, I don't want to close without offering you an opportunity to sign up to be in the trial or to share this with your friends and family or anyone who's not eligible right now by the EUA. This might be a good opportunity to get a vaccine. I want to thank a group of people that I don't usually ever interact with in my regular career other than the Schubert, the OCTR, and the Research Foundation folks, CCTST and RPAC. As I said, these folks have been amazing and great, and we couldn't have done this without them. And I just wanted to take a moment to say thanks. I'm sure I missed someone, so I'll try to tidy this up on my next presentation. But I certainly didn't mean to miss anyone.
Thank you, Michelle, for your presentation. It makes me tired watching it every time, all the work that you've been doing. I wanted to give you an opportunity, since this was recorded earlier, to maybe give us an update on where things are. And we really appreciate you taking the time to join us today.
Thank you, Crystal. Boy, this brings me back to when I was very sick with allergies, so I hope I sound a little better today.
Michelle, I can't really hear you. I'm sorry.
Okay, let me put my headphones on. Okay, is that better?
Yes. Thank you.
Okay. Thank you. I didn't listen to myself, so if you have specific questions, I hope I can remember. I hate hearing myself talk. I just pulled it up a second ago. We've now enrolled about 1,350 people into trials, both adults, adolescents, and now we're doing the Pfizer trials for children down to age 2. And we expect the Moderna and Pfizer trials for children down to age 6 months to start in the next month or so. So we continue to be incredibly busy and a little overwhelmed, but all for a good purpose.
Right. Does anybody else have any other questions for Michelle?
Oh, I can't hear you now. Okay, I did not hear you.
I just asked if anybody else had any questions for
Okay,
you.
okay, thank you, got it.
Yeah. Gordon?
Sorry for hogging the questions. Thank you very much for that, Michelle. It was really, really interesting, and it's fabulous work that you've all been doing. It really, really is.
Thank you.
I wonder if you could tell us more generally about what the impact has been on the perception of clinical research, and maybe about the role of the clinical research nurse. Has that changed over the period?
I would say yes. I think overall we're kind of a hidden gem, invisible group over here. We're off campus, and so we're not a group that people really see on campus very often. We do have a lot of employees that typically participate in studies, so that would be kind of our main interaction with the hospital. So certainly, you know, our group's been on the news every day. They've been over to take photos and videos. And so I think we're definitely in the limelight now in a way we've never been before. And I think impact on clinical research is a little interesting. We've been involved in that community engagement core for over a year now. And so I think we have visibility in community groups that we haven't had a lot of in the past, which is great. And to kind of come full circle for that group, starting tomorrow, our group is going to participate in some community events, going out and actually giving the Pfizer and Johnson & Johnson vaccine to the local community, some of the underserved populations, using our mobile care clinic. So we're excited to be able to bring that whole full circle from research to actually making sure the community is getting vaccinated even outside studies. I've had about 4. I've had more than that, but I've had the opportunity to actually hire 4 of the PICU nurses to bring into my group. So I think that's an amazing addition to be able to start training that next generation of highly experienced clinical nurses to now transition into research. My senior coordinators are dead and dying and hope to revive this summer, but yes, it's still quite busy here. Did I cover most of that?
Yeah, sure. Because I mean, I think I think there globally there's a real opportunity in terms of the perception of research and the understanding of the role of the clinical research nurse. And I think if you can use that to help to attract highly skilled nurses into the role, then that's I think we need to kind of grab every opportunity to be able to get good people into the roles. So that's interesting to hear. Thank you.
So one of the things, just to add a little bit, that we've started to see as we move toward start initiating some of our non-COVID research that's been on hold for a year or so, people aren't very interested in non-COVID studies. So I'll be curious to see how, you know, has the world completely changed and that's going to be super hard for a while, or people just need to get mostly vaccinated and then they'll start looking at other projects. So that's been a little surprising stumbling block that we weren't expecting.
Okay, thank you.
I apologize if I don't say your name right, Safilo. I just tried to unmute you.
Hi, colleagues. Can you hear me?
Yes, we can.
Okay, that's fine. Thank you very much, Michelle, for the presentation and for taking us through the journey. It was really fascinating. 3 questions. One, how have you navigated the politics in the US. Unfortunately, you were all in the limelight, so we know what was happening. So did you navigate that? Because I'm sure there was some pushback or some negative effect in particular. The number two, the electronic consenting. How did you navigate the legal aspects of that? Because there are arguments against electronic consenting, especially if someone is not there. And then lastly, is about, you mentioned that you were making calls. Again, privacy issues, because we are struggling with that. Well, we are a third world country, so maybe in a first world country, it's quite different, because I'm in South Africa. Maybe if I can just squeeze in one more last one. And this one is around this, what we've also experienced in South Africa, because studies have been started, and then because we moved to another level, because we use different lockdown levels in South Africa, we would stop and start and stop and start. Did you have something like that? And how did you mitigate negative impacts against that if you had it? Thank you very much.
Okay, so you might have to help me remember these as we go forward. So the politics, I think we've been able to stay out of mostly and just stay on mission and move forward. The things we've focused on most are trying to make sure that we have great diversity in our trials. And in order to do that, we really had to be very focused on community education and getting out there and talking to the community, hearing what they have to say, listening to their hesitancy, trying to provide them with information that makes them comfortable, and just trying to combat some of those negative political influences. And I feel like we've done a very good job with that. We've been able to get in about 20 to 30% diversity into all of our trials, which is much greater than our local population. Let's see, you're going to have to ask me the other questions again, one at a time. We have not had any starts and stops on our study. It's been full tilt since the moment that we started, and we've just been rolling back to back to back. So I think we would actually kind of appreciate a little halting moment. The only starts and stops have been through in the phase 1 portions of the trial. And I don't think the participants really felt that, like the nursing staff, where they would look at the data on Friday to Sunday, and then Sunday night they would say, we want you to enroll this many people of this age group next week, and then you're scrambling on Monday to get those all scheduled. So we kind of crumped over that, but I don't think our participants knew about those kind of starts and stops. Okay, ask me your other two questions.
It was around electronic consenting.
Oh, electronic consent. So we actually moved to electronic everything about 2 years ago. And honestly, I don't know how we would have done all of this if we had not been all electronic. For the Pfizer trials, we are able to use our electronic process, which is through REDCap. And then we had to move that actually into their system, which is, I think, called Florence. For AstraZeneca, we just use our own electronic REDCap process, and that's worked very well for us. All the initial consents were actually done on site, so remote consenting was more for additions to the reconsenting for new information that came out in the consent. And a lot of that wasn't really safety information, but more like, oh, this many people are in the trial now, things that weren't very urgent. When we did do remote consenting, when at their next clinic visit, we did revisit all that just to make sure they understood everything and documented that we reviewed that with them. I'm not sure if we had the FDA audit when I did that first talk, but we have already survived an FDA audit, and they've looked through all of our information. So far, I think we're okay with our processes.
Okay, thank you very much. Then the last one really was around conducting maybe interviews or going through questionnaires telephonically.
So yeah, we push out a lot of the questionnaires through REDCap. And so our folks are used to those survey kind of modes. And so we are actually able to push those out. They log in and then they're able to answer their surveys. And then those responses come back to the nurse coordinators who review them. And then if they, are having illness or symptoms or anything that needs to be addressed right away, then we contact them by phone. And that's been a lifesaver for us. I don't know how we would have really called 13 or 1400 people every week, and then sometimes more than that. So that process has been great. And if anyone's interested in that and they don't have that, we're happy to share that.
Thanks, Michelle. Any other questions for Michelle? Well, thank you so much, Michelle.
Thank you for inviting me. I've enjoyed the day so far, and I appreciate being able to participate in this event.
Oh, thank you so much. Thanks, Michelle. Now we're going to move on to our next presenter, Rachel Baker. She is a nurse researcher with TriHealth, and she noticed an educational need for not only healthcare workers, but also the community that was not being met. Oh, sorry, passed it. So Rachel pre-recorded her talk, but she also is on the phone for questions afterwards. So I'm going to go ahead and share Rachel's presentation. You gotta love technology. It'll just be a second. Let me know if you can't see my screen.
Hi, I am Rachel Baker, a nurse researcher at TriHealth, and I am honored to be here with you today celebrating Nurses Week and the unique role of clinical research nurses this week. I'm going to tell you a little bit about a project I was involved in when we found a need, and that need was filled by nurses with some experience in research. "2020 was named the year of the nurse, and what a year it was. As you all know, in the past year, nurses have been at the forefront of providing care to patients with COVID-19 during this pandemic. For many nurses, work has changed to new protocols for rationing personal protective equipment, to providing care maybe in new settings and expanding hospital capacity. This has been a year when healthcare and nurses have been at the forefront of the public's attention. Public health officials have been visible, advocating for mask wearing, social distancing, and hand hygiene. And it's been a year of eagerly awaiting for a safe and efficacious vaccine to end the pandemic. However, having a vaccine available isn't all that's needed. We need people to agree to take those vaccines to really see cases decrease and see the light at the end of the pandemic. Our nursing leadership team read an article, which is shown on this slide. It was published at the end of October in 2020, and it describes a national survey of more than 13,000 nurses. And they found that at the end of October, only 34% of nurses said that they definitely intended to get a COVID-19 vaccine when one was available to them. In the article, the current ANA President Ernest Grant stated, "These findings underscore the gaps that need to be addressed quickly and effectively. Education of nurses and other healthcare workers must be a top priority to ensure a high level of vaccination among these essential workers." So we wondered whether this same COVID-19 vaccine hesitancy was occurring among our nurses in our system. To give you a little background, TriHealth is a large healthcare system in Cincinnati, Ohio. We have 5 major hospitals shown on this slide, multiple freestanding emergency departments and surgery centers, and over 120 ambulatory care settings. And throughout the whole system, we employ over 3,000 nurses. So in the very beginning of December 2020, so before an EUA had been granted for any of the COVID-19 vaccines, we sent an anonymous survey to all the nurses in our system. And just 1 week later, we had received over 1,600 responses to our survey. So as you all know, being involved in research, that is a fast and big response rate. So we looked through those responses, and what stood out to us is a lot of nurses talked about obtaining information about the COVID-19 vaccine from social media and realizing that that wasn't the best source to use, but stating that they just didn't have enough time to really look at the sources they were viewing to see if they were evidence-based or not. And so they acknowledged that they were using unreliable sources to get information about the vaccines. So these unreliable sources led to misinformation about the vaccines and ultimately to vaccine hesitancy in our nurses. In the beginning of December, our rate was very similar to the national survey, and 38% of our nurses said they definitely intended to get a COVID-19 vaccine when one was available. We had a free text portion of our survey, and for all the nurses who stated they weren't sure if they would get a vaccine or they definitely wouldn't, we asked them what kind of hesitations or concerns they had. And these are the words that came up the most frequently. A lot of nurses talked about concerns about long-term impacts of the vaccine, side effects and safety. Several people talked about having tested positive for COVID in the past and thinking they didn't need a vaccine. Others talked about the vaccine being too new or approved too quickly. Some people just stated they needed more information. And then there were specific concerns. We had several nurses talk about currently breastfeeding, being pregnant or wanting to become pregnant and concerns with that, having an autoimmune disorder, and then distrust in the FDA approval or politics around the vaccine. So what we did with this, we got together a team of nurses, and most of us are pictured here. I am in the front of this picture, and then Kim Carter is in the middle, and Michelle Huff is in the back. And then our director, Sharon Brem, also assisted with the project. So what we decided to do was get together nurses that had some experience with research and develop a COVID-19 educational video series where we would pull together the research and data around the vaccines to provide easily to our nurses. We called the vaccine video series, Have You Heard? So we were kind of playing on the word heard. We were hoping that the series would combat misinformation that nurses had already heard, and then hopefully it would result in the nurses gaining confidence in the vaccines and deciding to become part of the herd of vaccinated people. We realized that many of our nurses were clinical experts, but they weren't so comfortable understanding trial data and research. So we took nurses with some experience in research and had them take the reins in explaining the research behind the vaccines to our nurses. We created short animated videos that explained the data. The first video we created explained the 94 to 95% efficacy that was being reported for the Pfizer and Moderna mRNA vaccines. And so I was going to play that for you to see one of the videos. So bear with me for 1 second. years, and I'm really excited about a new initiative that we are starting to provide short videos to help answer some of the questions nurses have come to us about the new COVID-19 vaccines. So we've all heard tons of rumors, I'm sure, information that it's hard to sort out what's true and what is not true. And so we're going to try to take all these myths, all these questions, and create a video series to quickly answer the questions for you. Today, we're going to start on efficacy. There are a ton of COVID-19 vaccines in different stages of clinical development and in clinical trial, but only one to date on December 15th has been approved by the FDA for emergency use, and that is the Pfizer vaccine. So we'll be talking about that. This is a really picky word explanation, but I want to point out that efficacy is the performance of this vaccine under ideal or controlled circumstances, like in a clinical trial. Effectiveness is how this vaccine performs in the real world conditions. So right now we just have efficacy data. This is an overview of vaccine trial design. The studies that we're looking at are phase 3 clinical trials, which focus primarily on safety and efficacy. Participants enroll in the trial and are randomized to either half of them will receive the vaccine and half receive a saline injection. For both the Pfizer and Moderna study, participants receive 2 injections, either 2 vaccines or 2 placebos, 3 to 4 weeks apart. And then for 7 days following each injection, they report symptoms back to the study team. Then, for the duration of the study, they report any COVID symptoms. So let's look at the data from the Pfizer trial. So far, they have enrolled over 43,000 participants, and approximately half were randomized to receive the vaccine, and approximately half received the placebo. And what we keep hearing is that it has a 95% efficacy. So what does that mean? What people mistakenly think this means is that 95% of vaccinated people don't get COVID. In the study, that would mean looking at the vaccine group, 95% of those didn't get COVID, leaving over 1,000 vaccinated patients getting COVID. Is this true? No. In the study, only 8 vaccinated patients got COVID. I'm going to walk you through how the statisticians actually determined a 95% efficacy and what that means. So as I said, only 8 patients in the vaccine group tested positive for COVID, and 162 in the placebo group tested positive. How we calculate the vaccine efficacy is take the risk of getting disease without the vaccine, which would be 162 out of the total placebo group, minus the risk of getting COVID with the vaccine, which would be 8 out of the total vaccine group, divided by the risk of getting COVID without the vaccine. In red, I calculated the risk of getting COVID without the vaccine, and in blue, the risk with the vaccine. So we do without minus with over without, and then when we calculate that out, we get 0.95 or 95%. What this means is if you get the vaccine, you decrease your relative risk of getting COVID by 95%. On the graph, the red slope are the patients who had the placebo, and as time moves on, they're increasing incidence of COVID, whereas the flatter line is the vaccine group. Just as I was getting ready to publish this video, Moderna released their data, and so I created a slide explaining the 94% efficacy of Moderna. It is great that 2 vaccines that are very similar would have such a similar efficacy rate. It makes me very confident in this data. I hope this video about vaccine efficacy was helpful. While there's lots of questions about the COVID vaccine, I think efficacy is pretty well documented, and we'll keep watching data to come. If you have ideas for future videos, feel free to email one of us listed on the slide, and we will address your question. Thank you. All right, so that gives you an idea. We addressed each topic quickly and just a quick little video that were easy to watch. So in addition to the efficacy video, we created 11 more videos. We did one on safety, which looked at kind of to be expected reactogenicity kind of symptoms, and then adverse events that had occurred in the trials. We looked at the idea of long-term effects in vaccine and what's been seen with other vaccines. In the middle of making the videos, a rumor started going around that people could get cytokine storm from the vaccine, so we discussed that. Then we did a video on reproductive issues. So we talked about breastfeeding, pregnancy, and infertility. Next, we did a video that looked at just the mRNA technology and how these vaccines were created. We did one about whether people who had been previously infected with COVID-19 should consider getting vaccinated. Then we did a video that looked more broadly at why people should get vaccinated. So we explained herd immunity. The four of us who created the vaccines each spoke about our personal whys, so why we each got vaccinated. We looked at racial disparities in COVID infections and with the racial breakdown of the trial participants. We looked at the vaccine development process and approval process. And then we looked at if you decide to get vaccinated, what to do on vaccination day. And finally, the first 11 videos had all been created when just Pfizer and Moderna had EUA approvals. And so once the Johnson & Johnson Janssen vaccine was received emergency use authorization, we did a video on that vaccine as well. So I am going to show you one more in this presentation. We're going to look at the herd immunity video. Pathogen. So on an individual level, if you have no immunity to something and come in contact with that pathogen, you possibly could get sick. If you have immunity to that pathogen, either because you had a natural infection and recovered from that, or you were vaccinated against it, then when you come in contact with the pathogen, you're less likely to get sick. Herd immunity is when we zoom out and we look at immunity at a population level rather than an individual level. So in this image, the individuals in green have immunity, either because they had COVID-19 and recovered, or they were vaccinated against it. Herd immunity is the idea that the person in the middle might not have immunity to a pathogen, but the more people in their herd or community that do have immunity, the less likely they are to get the pathogen and get sick. To see how this makes sense, let's look at this image of a population or community. In this image, the red person is infected with the pathogen, and the blue people have no immunity, so they're susceptible to that pathogen. The red person exposes the disease to several others who then become infected. In this image, the people who become infected turn red, and the original infected person becomes immune once they recover, which is depicted by yellow. You can see in a population that started all blue or all susceptible and not immune, how fast this disease spreads. Let's compare this to a community where you have lots of immune people, either because they've recovered from the disease and built a good adaptive immune response, or because they were vaccinated. Remember, these immune people are yellow in the image. When a red infected individual enters a population with many immune people, there are fewer avenues for the pathogen to spread. When enough people in a population become immune so that the rest of the people become protected by proxy, the group has achieved herd immunity. This is really important for individual people in the population whose immune systems are too fragile to develop immunity from acquired infection or through vaccination. So the big question, how many people have to be immune for us to reach herd immunity? This is called the herd immunity threshold, and it's different for each disease because it depends on how infectious the disease is. The more infectious the disease is, the higher the proportion of the population that needs to have immunity before we have herd immunity. Remember R0 that we've heard about a lot? It's the average number of people that one person infects as they spread the disease. So we calculate herd immunity threshold by taking 1 minus 1 divided by R naught. The R naught for COVID-19 is around 3, and so if we plug that into the formula, we need about 67% of the population immune to reach herd immunity. With a US population of over 300 million people, that means we need at least 200 million of us immune. Right now, the estimates are that about 20% of our population or less is immune. So the safest and fastest and honestly probably only feasible way that we're going to reach herd immunity is through vaccination. This figure puts COVID's herd immunity threshold into context. The threshold to obtain herd immunity from past diseases has ranged from anywhere from over 90% needed to be immune for measles down to about 25% for H1N1. Past videos have focused on topics like efficacy and safety of the vaccine and have really looked at the individual level of vaccines. This video was a little different because we wanted to display the power of vaccines at a population level. In line with this idea of the collective power of the vaccine, the U.S. Conference of Catholic Bishops put out a statement saying that receiving the COVID vaccine ought to be understood as an act of charity towards the other members of our community, and that being vaccinated should be considered an act of love of our neighbor and part of our moral responsibility for the common good. While each of us needs to make a decision that's right for us personally, it's important when making that decision that we consider the collective power of our decision to vaccinate and to protect those most vulnerable in our community. Great, so that gives you an example of another video. We really created these to educate the nurses in our system, but our marketing department liked them and adapted them to a more general audience and published them for all of our systems team members on our healthcare systems intranet. And then even some of the videos they posted on our system's external website for community members. So it resulted in lots of education. But looking just at our nurses and being into research, of course, we had to evaluate how our videos did. So Press Gady put out a survey result that the two things that impact vaccine acceptance or hesitancy are people's confidence in the safety of the vaccine and their confidence in the efficacy. So we asked those two questions. These are the results from the baseline survey. So before people had seen the videos, we asked them how confident they were in the safety of the COVID-19 vaccines. And as you can see, if we look at very confident and somewhat confident together, it's about 65%. However, after watching that videos, that went way up and we had about 89% of our nurses saying that they were either somewhat or very confident in the safety of the vaccine. Similarly, we asked how confident they were in the efficacy of the vaccine, which you can see at baseline was about 70-ish percent were either very confident or somewhat confident. And afterwards, this came up to close to 90%. So lots of increase in confidence in the safety and efficacy. We knew it was important for nurses to have accurate evidence-based information so that they could make an informed decision about whether to get the vaccine personally. And we also knew that the more vaccinated nurses we had practicing at the bedside, the safer our patients would be. Finally, we knew that our patients would also be asking about the vaccines when they accessed our healthcare system. And so we wanted our nurses to be armed with evidence and data to be able to talk about the vaccines. So this shows answers to a question we asked: how comfortable are you discussing the COVID-19 vaccine with your patients? So these were the responses at baseline. And then after watching the videos, nurses were much more comfortable discussing the vaccine with their patients. So we were excited to know that there was an increased confidence in the vaccine and increased comfort level talking about it, but we wondered whether this resulted in a change in behavior. So did people change what they were going to do personally? So as we talked about, at baseline, only 38% of our nurses said that they definitely would get the vaccine when it became available. So about a month later, the vaccine had been available to healthcare workers for about 3 weeks. We asked them whether they got it or not. And we had an astounding 87% of our nurses ended up getting vaccinated in those first 3 weeks. And the percent went up as time went on, but this was a pretty drastic increase from just a month prior. We collected qualitative data that supports these numeric data. And my favorite quote was one nurse that said, "If it had not been for the vaccine video series, I do not know that I would have received the vaccine. They were very informative and well done. They answered all the questions that I had and encouraged me and educated me on receiving the vaccine without the feeling of being pressured to do so." And that was really our intention, was to give people evidence-based data and information to make informed decisions for themselves and not to make anyone feel pressured. We started this project to address a local problem of COVID-19 vaccine hesitancy in our system, but it became so much more impactful as it highlighted to us the powerful voice of nurses at the forefront of education. Time and time again, nursing has been recognized as one of the most honest and ethical professions, which is an honor, but with that honor comes an obligation. We recognized this obligation and decided to add science to the discussion of vaccines and dispel misinformation with data. And through this process, by being heard in our videos, we helped to create the herd. So thank you very much for watching this. I hope it was interesting to you, and thank you all for everything you do. Happy Nurses Week.
Thank you, Rachel, so much for that presentation and for those videos. It was such a educational need that was met, and I am so thankful that you were able to do that and get that information out to not only healthcare workers, but the community. So we really appreciate that.
Yeah, thanks for letting me present about it today.
So if anyone has any questions for Rachel, just let us know.
Thank you. I don't have a question. I just want to say thank you so much for doing research almost from the bedside, seeing a problem in the clinical area and then doing research about it. I think in my experience, I'm also from South Africa, and my experience is people are scared of research. They think this is this highfalutin thing, and you have to have many degrees before you can do that research. So thank you so much for this presentation.
That's interesting that you bring that up, that we put these videos out, and a lot of nurses, you know, at the bedside that were very clinical experts, we got the feedback that they were really interested in research, you know, and they thought they hated research. It was, you know, the class they didn't like at school. But now that it's pertinent, now that it's real life, I need to decide, am I going to vaccinate or not? Now I want to understand the research. And so we were able to use that critical moment to kind of have some people catch the research bug. And once the video series were over, we started getting all these emails saying, well, tell us more about other research happening. And so what we've done since the videos is started an email list of nurses in our system that are interested in research. We just said, if you're interested, reach out, and once a week we'll send an update. And you know, there's so much happening every day with COVID research. In the United States, the Pfizer vaccine was just approved or authorized for 12 years old and above yesterday. And so yesterday we sent out an email to this group about the pediatric data and explaining that. And so, you know, a group of nurses that were very clinical focused. Our hospital system is very clinical. It's not a ton of academic research. I think we are up to over 400 nurses that have asked to be added to that email list, which, you know, before this, I don't think I would have had hardly anyone wanting to get
Yes, exactly.
I got lost for a second. I think I'm back.
Yeah, we can hear you, Rachel.
Okay, sorry, it said I came off for a second.
So thank you.
Yeah, so thanks for the comment. We noticed that same thing.
Any other questions for Rachel?
There I'm back. I couldn't see everything for a while. Yeah, so we're hoping that this, we can use this or initial excitement, to have people now be able to look at issues at the bedside that we can, and people won't be so intimidated by research, and we can do some more projects to help practice even outside of COVID, hopefully.
Rachel, I think you've always done such a great job of simplifying research and making it relatable. So
yeah,
keep up the good work.
Thanks for highlighting this today. I was excited.
Yes. We'll give everyone another minute to see if there's any questions. All right. Well, thank you so much, Rachel.
Thank you.
And then we're going to move to the next part of the presentation. The next part of the presentation that we wanted to share was our research nursing video that I believe has been shown numerous times at the IACRN, and hopefully you guys have the knowledge of knowing about it so that you can use it as well. It's been meant to be shared. So I'm just going to go ahead and show that real quick.
I think the number one question that most people ask me about being a research nurse is, do you have any patient contact? Do you actually see patients? And the answer is yes. Lots of patients, a lot of the time. That's the majority of our work.
They will give you the necessary means to be comfortable, whether that's lying down in a bed, sitting in a chair. If you have to have blood work, making sure that you're comfortable sitting down. They just facilitate all your comforts so that you feel relaxed and ready to participate.
After speaking with Belinda, who is the coordinator for the study, she calmed me down and helped me understand the right approach to research, helped me understand what would be involved in it and how it would help MJ in the future. After that, we decided to sign up.
I don't care who you are. When you get cancer, you right away go and try to search out what's my odds of living. My physicians suggested that I talk to one of the clinical study nurses.
I was responsible for making sure that he qualified, working with his doctor to make sure that everything was all lined up for him to get on the study. And then since then, really just maintaining him on the study, following the protocol how it's supposed to. We've had great results with JP on the study.
Not only something that offered some opportunities for me, but it also kind of gave me a way to give my cancer a reason.
A research nurse has to incorporate good clinical science with good patient care. So you're melding the two together. How can I protect my patient, keeping them safe, and maintaining the rigors of a clinical trial or of a protocol?
Probably the most common misconception is that research nurses are stuck in an office looking at a screen, going through charts and data and filling out forms. That couldn't be farther from the truth.
I was born with a lung disease called cystic fibrosis, so I've been doing
or been part of research for as long as I can remember.
We spend such long days together and lots of time together and seeing each other multiple times over, a course of 1 week or over the course of several months. And you really get to know just people as people.
They become your family. This is unfortunately, but fortunately, kind of like your second home. At least with my disease, you're in and out of the hospital your whole life. And these people, in a way, are your friends and family.
They're nurses, and so they are close to patients. They're intimately involved with who the patients are and what they have to go through. They understand exquisitely what is involved with patient care.
Well, the nurses really were the go-to people. They took really good care of you guys, but they also listened to what the boys had to say. As soon as the boys had any comments or concerns, they would listen. And if the boys wanted to tell a story, they would also listen. So through the course of the months that we came, we developed quite a good relationship really with every one of the research nurses.
Well, they had a really good sense of humor, and they would listen to us and help us with anything we wanted.
They are all much more than just nurses to me. They are just part of my life now. I mean, it's just really a cool feeling to know them. They're very good people.
Sorry, that video always gets me every time I watch it. It always brings me back to why we all do research nursing and all the roles that we play as research nurses. So I'm going to share our last slide. We just want to thank all of you for all that you do as research nurses. And that is our contact information. That's Lori's, myself, Julie, Michelle, and Rachel, all the presenters of today. Without all of you, clinical research nursing would not be where it is. So thank you to those who have been able to join in person, but also ones who are able to join online and watch this later. So again, thank you so much to everyone who is a clinical research nurse for all that you do. And thank you for the IACRN for being the only association dedicated to clinical research nurses. So we do have some time left for if anybody has any questions. Yes, I apologize. I couldn't see if anybody might have raised their hand. So if you did, just please re-raise it and I can unmute you. Gordon. Gordon, I think you might still be muted, possibly.
Because that's up. My microphone was up in the air. Crystal, I just wanted to say thank you so much to everyone in the Ohio chapter, because that was really, really interesting, and it really shows the fantastic work that you're all doing there. So you should really be proud of yourselves. Thank you so much.
Oh, thank you.
Thank you, Gordon. Happy Nurse Week, everybody.
Yes, happy Nurses Week.
Thank you.
Thank you so much. And we look forward to hearing everybody else's presentations as well.
Bye, Elise.
I just unmuted you, Elise. I don't know if you wanted to say something or you're just waving.
I was waving to say goodbye and thank you so much, but so let me say that in words as well. Thank you really much for a comprehensive overview of what you do and what is possible in clinical research and with clinical research nurses. Thank you so much.
Oh, thank you.
Thank you.
Gordon, can I ask you a technical question? I just want to make sure I get off of here correctly.
Okay, bye.
Bye, everyone.
Bye, Elise. Thank you.
Thank you so much.
I'll try.
I just want to make sure I'm supposed to end, right?
Leave and then end for all, right?
Yeah, I think so.
Okay. Okay. I just wanted to verify those steps because I don't want to end it for everyone that nobody else can do their presentation.
You're going to end soon.
Oh, well, thank you so much to everyone who was able to attend.
Thank you. Thank you.
Have a great rest of your day or evening or night, whatever time it is, wherever you are.
I'll for my dinner now. Thank you.
Thank
All right,
you.
take care.
Bye.
Bye.